Hi, Joy Horner here, Thoughtful Thursdays. I didn't get one to do I didn't get to do one last week because I was away, and as you can still hear, my throat's a wee bit croaky as I've got the end of a cold. Uh yeah, so I've been thinking about vaginal examinations like you do as a midwife, and it was prompted by speaking at the University of Huddersfield last week. Um, And one of the student midwives has contacted me to ask about vaginal examinations and, yeah, her feeling uncomfortable around the subject. Not just because it's an awkward thing to do, but because she herself found them really quite invasive during her labour. So I've been thinking this morning and wanting to get a few words down in case I don't get a chance to write this down. It would be great if it were a blog post, but I never seem to have the time to sit down at my computer and bang it all out. So here are the thoughts off the top of my head. Okay, so a vaginal examination is a very limited tool we have to assess the progress of labour. Very, very limited. And it is only necessary on the whole to do it routinely, or to offer it routinely, not to do it, to offer it routinely, if we don't have continuity of midwifery care. So if I attend a birth of one of my clients, we've already had discussions about internal examinations. I've told her the nice guidelines and local policies and things, and she's told me how she feels about this, and then we go forward in labour discussing whether one would be helpful or not. Now, I know when my clients are in labour because they know when they're in labour. If you ask a woman who is having contractions and they're really, really uncomfortable if they're in labour, and they tell you yes, then they're in labour. And it really doesn't matter what their cervix is doing at all, because their body is getting ready to propel the baby out of the uterus and into the birth canal and into the world, and that's labour. It's really hard to define when a labour starts, and we're doing lots of women a huge disservice by telling them they're not in labour if we do an internal examination and find their cervix is less than 4 centimetres dilated. You're not in labour, go home. And again, at the Huddersfield University Study Day, I heard from Helen Sparrow, who's just done her PhD on this very subject, that many women are therefore sent home from hospital and are traumatised because the baby's arrived all of a sudden at home after being told they weren't in labour and being sent home. Now, this is really traumatic for lots of women and their partners, and the babies, born into a state of panic rather than a state of, calm welcoming that we'd all wish for our babies. Yeah, so I think we do women a great disservice doing internals, really. Let alone the downside of internals, and there are many, many downsides. Okay, top of my head, the downsides of internals. We can introduce infection. If a woman's membranes have released, we know there's then a possibility of ascending infection, isn't there? This is why we offer to induce women to have their babies within 24 hours of their waters releasing, in case infection ascends and gets to the baby. Small chance of that, but there is a possibility, it does happen. Now, the chance is increased if we do an internal, because guess what? We are putting things from the outside inside. And when women's waters have released spontaneously and they're waiting for labour to start, what do we say? No baths, only showers, don't put anything in the vagina, don't have penetrative sex with your partner. We don't want anything going in there that's going to introduce infection. So we come along with our sterile speculum and stick it in there, to confirm that waters have broken. Now, if a woman comes in with a soaked pad, of clear water, maybe slightly yellowy or pinky sometimes, isn't it? I mean, not like meconium, but you know what I mean, straw coloured, clear. And it smells slightly of almonds or semen, some people say. Have a sniff of that pad. That is Lycor. Now, what you as a midwife can't tell, whether you do a speculum or not, is if it's the forewaters or if there's been a hindwater leak. So what on earth is the point of doing a speculum examination? Never really got this. And what's the difference between doing a speculum examination and a digital examination with our fingers, with sterile gloves on? Tell me the difference. Someone please tell me the difference, because it's always baffled me. We are still putting the sterile instrument or gloves through the air, getting all the bugs in the air, maybe coughing on our hands, maybe, definitely touching the woman's external genitalia and pushing whatever's outside in and up towards the baby. So we can introduce infection. We can rupture people's membranes if they haven't been, if they haven't released spontaneously. We can actually break them, and whether we do this intentionally or not, if you're poking around a bag of water, pop, easy, whether you intend to or not. And I know some midwives possibly do intend to speed the labour up. Other nasty things we can do while we're doing an internal is, we can try and hasten the labour along, can't we? We can do a sweep. And again, I've seen it done without the woman's consent or even knowledge until she realises this is a really, really painful internal she's having, and hopefully tells the midwife to stop. And then afterwards, the midwife may say, "Oh, I just gave it a little sweep for you, just speeding it up for you." Yeah, great, fantastic stuff. We all want our labours to be over quickly, but do we want the pain to increase? Do we want things to be increasing at a level that we can't keep pace with? Because normally labour progresses at its own rate so that our hormones can build up and our oxytocin and our endorphins and all the rest can build up so we can cope with it. What if suddenly you're ramped up to the next level and you can't cope, and then you've got to have an epidural or pethidine or something that you didn't want? I know, it's a great disservice. What other things are entering my head about an internal? There's so much to say on this subject. I think that the most important thing to say is that about 1 in 3 to 1 in 5 women have been abused some way in childhood or adulthood. If we imagine it's 1 in 3, because we really don't know, not everyone reports it. And that woman may or may not have disclosed to her midwife. Probably not. I don't think anyone disclosed to me on the NHS, and yet many, many, many of my independent clients disclosed to me. I don't know, my caseload, about 80% seem to have had some abuse in childhood or adulthood. Now, whatever we do to a woman during labour, particularly to intimate parts of her body, are likely to trigger any bad feelings of bad stuff that was done to her before. So imagine, we don't know when we're on labour ward and we're told to go and assess this woman, we're taking over her care, and we introduce ourselves like good midwives and say, we need to do an internal, it's 4 hours since your last one, and the woman agrees. She's in heavy labour, she hasn't got time to think and process this, she's really, really vulnerable at this time and really suggestible. So thinking that the professional knows best, she agrees to it. We haven't got a very good reason to do it, except she's on labour ward and we want to know she's progressing, because if she's not, we've got to hurry it up, because we've got more women waiting. There's cynical me, but there's the truth. So we've introduced ourselves and laid everything out and go to do that internal. Doing it left-handed here, I'm actually right-handed. And what do? again, I've seen a lot of midwives, okay, or not even that, not talk, not make eye contact with the woman, push, prod, have a good rummage around, not even look at the woman, not even tell her what's going on, and then take your fingers out and go and write your notes. And the woman's saying, is it all right? What was it? What did you find? Because we've gone in there for a reason, presumably. Imagine how traumatizing that is for a woman who probably wasn't talked to and wasn't communicated with, or was in a harsh way during her abuse. Someone looking very disinterested in her and how the experience is for her. Now, I urge you all to read Spiritual Midwifery, because there's there are lots of fantastic pictures in there. But there's one in particular, and I can't remember the midwife's name, but the midwife is doing an internal, and you see her face like this. And this is a much kinder way to do an internal. If we look the woman in the eyes, if we make sure we have got absolute informed consent, so we tell her the reason that we want to do an internal, and if it's just that this is a routine thing that we do, that's not a good reason. She has to know this is just a routine thing. It's unlikely to change the care that we're going to provide you, and it might be a bit uncomfortable. Then she's very unlikely to accept that, is she? There are cases where I do like to suggest regular internal examinations. Again, my clients don't always accept. But if someone's having a vaginal birth after cesarean, or a breach, something really, really out of the ordinary at home, where we need to make a good plan if things aren't progressing, and get the woman to hospital, then sometimes it's worth suggesting. It's certainly not a thing that we have to do or that I rely on. Because do you know what? We can tell when women are in labour. A good midwife doesn't have to do internals. I don't have to do an internal on a client expecting a breech baby, or one having vaginal birth after cesarean. It just gives me an extra heads up if things aren't going really, really smoothly. If I'm worried that the labour has stalled or doesn't look like it's progressing, it's a useful tool to then make a judgment about whether we continue at home or suggest going in. So we need to get truly informed consent, tell women the downsides to this as well as the upsides. We might cause infection. We know that women get more infections with the more internals they have in labour. Really think about why you're doing this. Get the woman's consent and look her in the eye and say, I will stop if this is really uncomfortable for you. You just have to tell me to stop, and I will stop straight away. And you maintain eye contact. You ask her to open her eyes if possible and look at you, and you check in. Because some women that have been traumatised actually shut down if bad things are happening to them. They dissociate. So it's like their mind switches off to the bad things that are happening. So they might be looking at you and they're not saying stop, but that doesn't mean it isn't traumatic and that you should carry on. So you need to check in with that woman and say, is it still okay for me to continue? And unless you get an affirmative, stop what you're doing. If you've got any slightest hint that you've been in there a while and you still can't find what it was that you wanted to find out, but she's looking dissociated or, not communicating with you, check, is it okay to continue or not? And for goodness sakes, if the woman says